We are live.
Good evening and a very warm welcome to Lecture 502 of Ophthalmology Clinics Exam Special at iFocus. Today we have Dr. Devesh Kumawat to guide our postgraduates for an approach to a long case in retina. Dr. Devesh Kumawat has done his MBBS from AIIMS Delhi and he has done his MD Ophthalmology from AIIMS Delhi as well with a gold medal. He's also completed his FRCS Glasgow, FRC of London, FICO, FAICO in Retina and FICO in UVA. Currently, he's working as the assistant professor at Dr. RP Center of AIIMS Delhi. He's also the associate editor for Delhi Journal of Ophthalmology. He's the recipient of several prolific awards, including the Allergan Academic Achievers Award, Dr. V.K. Kaldra Memorial Trophy for Delhi Ophthalmic Society Quiz, a Best of IJO for article Sunny Side Up Egg with Red Sus Appearance at Macula, Certificate of Merit by IJO for Cobalt Blue Light Unit Filter, a smartphone attachment for blue light photography, IJO Gold Award for the article Role of Additional Posterior Barrage Laser in Type 1 Zone 2 Retinopathy of Prematurity, and AIOS International Heroes Award. He has more than 80 PubMed indexed research publications to his credit, and he's the editor of educational book on diabetic retinopathy by ARC and ophthalmology section, the 5-minute clinical consult. With this, we welcome you, sir, and over to you.
Thank you, Dr. Mega. So is my slide visible?
Yes, sir.
Okay. So thank you, Dr. Mega. Thank you, Dr. Santosh Honawar and Dr. Mahipal Sachdeva, sir, for the opportunity to take the lecture in the famous and renowned iFocus series of lectures as well as classes for postgraduate students. So I'll be talking about the approach to long cases for postgraduate students pertaining to a retina case. Now, the common long cases that the postgraduate students in their MD/MS exams or DNB exams that they will receive or they will get the long cases for workup include predominantly it will be a rheumatogenic retinal detachment case or a proliferative diabetic retinopathy. Less commonly, it could be a central retinal vein occlusion or intraocular foreign body, dropped nucleus or intraocular lens, retinal vasculitis or macular hole. Most likely, these cases will be either in short cases or in OSCE. So commonly, you are going to see either a rheumatogenic retinal detachment or a proliferative diabetic retinopathy in the long case. Now, rheumatogenic retinal detachment could more commonly we see PVD-induced retinal tears that lead to rheumatogenic retinal detachment. Less commonly in young patients, you can have traumatic retinal detachments with dialysis. And now these patients will not only have fundus findings, but they will have anterior segment as well as maybe adnexal findings. So it is important to have a systematic examination in all these patients. Now, proliferative diabetic retinopathy is an important topic for long case in retina, and patients can have either have only proliferative diabetic retinopathy without any complications, or could have complications such as vitreous hemorrhage or diabetic retinal detachment, traction retinal detachment. Now, coming to the common long case on retinal detachment, so I'll briefly give a summary and then I'll come to the comprehensive workup of these patients. So it's a 48-year-old male patient, just a hypothetical situation that I'm presenting here. A 48-year-old male patient, a resident of Rishikesh, Uttarakhand. He complains, he presents with the chief complaint of sudden painless decrease in vision in the right eye for last 2 days. Now, he doesn't have any systemic illness. He's a mechanic by profession. Now, important here is to note that he's a resident of Rishikesh, Uttarakhand. So that is important. You need to take a history when you are dealing with, especially when you're dealing with retina cases, because such cases, because Rishikesh being a high altitude region, so the patient might have to travel to a high altitude region after getting treatment from you. If it's a retina related problem, then patient might undergo a vitrectomy or silicone oil or a gas tamponade. If gas tamponade is used in the surgery, then the residence of patient is important. If the patient is going to take a flight or is going to a high altitude location, then it is important. You should know the residence of the patient. And it is also important to know how far the residence of the patient is so that you can plan your follow-up with the patient as well. Now, the patient complains of vision loss in the right eye, so you have to inquire about the characteristics of the vision loss, like whether it is sudden onset or is it insidious onset, whether it is painful or painless. In addition to that, you have to inquire about certain additional complaints which are common in long cases of retina, such as retinal detachment, such as curtain in front of the eye, or the patient has associated flashes and floaters. So it is important that you elicit that history over here. Now, the patient further information that may be provided to you, or you may be asked to perform a visual acuity assessment also. If the information is not provided you, then definitely you will have to perform a visual acuity, unaided aided visual acuity as well, and then check the intraocular pressures. Most of the time, these may be provided to you. And then an anterior segment examination, again, a slit lamp, if it is available, then you have to perform an anterior segment examination. So in this patient, suppose the patient, the findings are already told to you that the patient has a crystalline lens with nuclear sclerosis grade 1. And the fundus, if you see, this is the picture. So it's a diagrammatic, it's not representative of the same patient with which I'm relating this history to. But suppose this is the fundus picture of the right eye, and the left eye fundus examination is grossly normal. So how do you go about working up this patient, and how do you assess this patient when you are working up your long case in retina during your postgraduate examinations? So you have to take the relevant history. We have already taken part of it, and then what other relevant history you have to take, that you have to focus on. You have to focus on the anterior segment finding. It's not only a posterior segment examination. You have to assess the anterior segment also, because it may have implications in the diagnosis and prognosis of the patient. Then posterior segment examination, thorough posterior segment examination, followed by description of the fundus findings. You have to note all the fundus findings. You have to document all the fundus findings. If it is not done, that then it may mean that you have not done that, you have not performed that step. And if it is not documented, then it can be taken as a sign of omission, that you have omitted that examination in particular. Now, after description of the fundus findings, you have to make a color fundus diagram. If it is if the findings are significant, then you have to come to the complete diagnosis and then offer the management plan also. So in the history taking, if such is the case, then you have to take the history of the vision loss. That is, how did the vision loss progress? Is it sudden onset or insidious onset, painless, painful? Is it minimal, mild, or moderate, or profound? Then does the patient have a field loss associated with vision loss? Was there any flashes or floaters associated with vision loss? So usually in retinal detachments, flashes and floaters might precede the onset of vision loss. So it is important to take a history of flashes and floaters. History of trauma is very relevant in posterior segment cases. You have to take a history of trauma, but take it by a pinch of salt, because often the patient would try to relate their symptoms to insignificant trauma that they might have incurred. So it is important that you remember the Cox postulates, that the patient should have history of significant trauma. There should be signs of there should be signs of trauma in the eye. And third, there should not be any treatable lesion in the fellow eye. The moment you have treatable lesion in the fellow eye, then trauma being the cause of retinal detachment may be less likely, unless you have significant findings of trauma in the affected eye. Now, you have to take a history of high-powered glasses, whether the patient used high-power myopic glasses in the past, or contact lenses, or had refractive surgery in the past, because those patients are prone to develop retinal detachments later on. Then family history of similar complaints. If the patient has vitreoretinopathy, then family history is also to be elicited. Now, history of previous retinal treatment, if the patient has had like laser or cryotherapy in the same eye or in the fellow eye, that history is also to be taken. Now, in pseudophakic patients, it may be important to elicit the history of cataract surgery. When was the cataract surgery done? Or was the cataract surgery prolonged, or was it complicated? Was there good visual gain after the cataract surgery? So that we know that whether it was a safe and uneventful cataract surgery, or was it a complicated cataract surgery with vitreous loss or not. Then you also have to take a history of YAG cap in pseudophakic patient, because in addition to cataract surgery, you can have YAG cap predisposing to retinal detachment also. So if the cataract surgery or yak cap has happened within the past 6 months of the retinal detachment, then you can attribute the retinal detachment to cataract surgery. It need not be a complicated cataract surgery. Even uncomplicated cataract surgery can develop, can lead to retinal detachments later on, because it can lead to progression of or acceleration of posterior vitreous detachment. Now, coming to the examination, it's not only the fundus examination that you have to perform, you have to perform a gross adnexal examination if it's a trauma case. If the patient gives you a significant history of trauma, you have to examine the adnexa, look for any defect in the bony orbital rim, look for any ophthalmos, any extraocular movement limitation, signs of trauma in the anterior segment, such as any sphincter tears in the pupil. If the pupil, most of often you will have the patient already pupil might be dilated, and you might have to inquire about the pupillary findings from the examiner, that I need to know the pupillary findings or undilated fundus, undilated anterior segment examination finding, that you can ask the examiner also. So sphincter tear is one thing that you need to look at. Then anterior chamber cells and flare, because your retinal detachment could have a lot of inflammation in certain scenarios when you are dealing with giant retinal tears or choroidal detachments. You can have cellular reaction in the anterior chamber, or it could be a case of vasculitis, or it could be an inflammatory CRVO or BRVO. So it is important that you focus on the anterior chamber cells and flare as well. If there is history of trauma, again you need to have a look at the angle recession, and again, in addition to angle recession, you need to have a look at the neovascularization of the iris and the angle if it's a diabetic retinopathy case. In this case, I've omitted that finding because we are dealing with a retinal detachment. Otherwise, you need to have a look at the iris and the angle for neovascularization if suppose it's a patient of proliferative diabetic retinopathy or retinal vein occlusion. Lens, you need to have a look at the crystalline lens opacity which could be there, because then you might have difficulty in assessment, difficulty in prognosticating the case, and difficulty in treating the case as well. Then phacogenesis, yes, if it is present, then it may point to a likely zonular dialysis, or it could be because of hypotony also in retinal detachments. Pseudophakic, I've already told. PCO is important because that will interfere with the assessment. Also important is a PC rent, which might be there, that will point to a complicated cataract surgery, or a YAG cap IOL pitting that may point to a history of YAG cap previously. Anterior vitreous Schaffer sign is important because presence of Schaffer sign in a phakic eye without any history of trauma, it points that there is a retinal break which is present, and through which the retinal pigment epithelial cells have migrated into the vitreous cavity. Now, when coming to the posterior segment examination, an indirect ophthalmoscopy examination is a must with 20 diopter lens. Start with the examination in supine position, and if required, you can perform it in propped up position as well, but it should ideally be done in supine position. In a dark room, adjust your indirect on your head. You should be well versed with the indirect ophthalmoscopy, all the knobs and all the filters that are there in the indirect ophthalmoscope. Align the binocular setting on indirect ophthalmoscope. Then it is important that you stand opposite to the quadrant that is to be examined, because the examiners sometimes may ask you to demonstrate or maybe examine the finding in front of them. So you have to stand opposite to the quadrant. So if you have to examine the inferotemporal quadrant of the patient, then you have to stand uh, uh, on the head end side of the patient, and uh, depending on the eye, you have to stand to the left or the right of the patient. Then normally in the retinal examination, you start with examining the periphery first, because you don't want to cause any photophobia and glare to the patient, and then you examine the periphery, and then you come at the end to the posterior pole. But in a retinal detachment case, you can start with the posterior pole examination first, so that you know what is the extent and configuration of the retinal detachment, and accordingly you can look for the breaks in the periphery. Then you should check all the four quadrants, all the clockers in all the quadrants, because you can miss some certain findings. And in the end, indentation is an integral part of indirect ophthalmoscopy in the long case. And you can perform an indentation ophthalmoscopy using socket indenter or the gas indenter. And indirect ophthalmoscopy is not the only posterior segment examination. You have to perform a slit lamp examination also with a 90D or 78D lens for a dilated fundus examination, binocular magnified examination of the posterior pole, because your indirect ophthalmoscope may miss scopy may miss findings of the at the macula, such as a subtle ERM or macular edema or a small macular hole. So it may be difficult to comment on such findings, or if there is shallow macular detachment. So these findings will be picked up on a magnified examination using slit lamp biomicroscopy. Now, then you come to describing the findings and documenting the findings. So when you see this fundus, you have to start first with the vitreous. And before that, even you can start with the distant direct findings, that how is the glow of the patient on distant direct ophthalmoscopy. Then you come to the vitreous. What is the clarity of the vitreous? The media is grading that is given by end of vitrectomy study from 0 to 4 plus, that you can describe the findings in terms of that. You can have certain retinal detachments, such as those with choroidal detachments or giant retinal tears, or those with history of uveitis. You can have significant media haze as well. Then you can have pigment clumps. The pigment clumps, they denote a PVR-B in case of retinal, PVR-A in case of rhegmatogenous retinal detachment, or if there is vitreous cavity hemorrhage or vitreous gel hemorrhage, that will point again to an avulsion of retinal vessel that might have avulsed during the tear formation. Then you come to the when you come to describing the retinal detachment, start with the contour, whether it is convex or concave, what is the quadrant or what is the location. Is it a total detachment? Is it a subtotal detachment? When there is more than three quadrants are involved, but there is less than total detachment, then you call it subtotal. There is no definite definition for near total detachment, but when only one clock hour of the retina is attached, then you can label it as a near total detachment. Then you have to tell the extent of retinal detachment extending from which clocker to which clocker in case of subtotal or near total detachment, such as in this case, you can describe that it is extending from 8:30 clock hours to 12 o'clock in the right eye. So when you describe the clock hour, then you have to also describe the posterior extent also. It's not only the circumferential extent, you have to describe the posterior extent, that whether it is reaching till the posterior pole, whether the macula is detached or not. So in this case, you can see that the macula is partly detached. Again, it's a two-dimensional picture, but a three-dimensional view on indirect ophthalmoscopy will better tell you about the macular status. And then slit lamp examination will be required to note whether a foveal detachment is also present. Now, how is the surface of the retinal detachment? Are there any corrugations present on the retinal surface? Any corrugations then will point to a rhegmatogenous retinal detachment and a fresh retinal detachment. Then you look for the breaks, the number of the breaks, the location of the breaks, and the type of the breaks, whether they are horseshoe tears, whether they are atrophic holes, or they are dialysis or giant tears, that you have to comment on. Whether there are peripheral treatable retinal lesions such as lattice degenerations or snail tract degenerations, or there are non-treatable lesions such as paving stone degeneration, what is their location, number, extent, that is also to be documented. Look at the PVR. Now, proliferative vitreoretinopathy can be pre-retinal or intraretinal or subretinal. So look for star folds, look for subretinal bands and sheets. And then you come to the final conclusion that whether it is a rhegmatogenous retinal detachment, tractional or exudative, and then you describe the findings as well. Then make a comment on the recent or the chronicity of the retinal detachment. If there is retinal thinning or demarcation lines or retinal cyst or neovascularization in the periphery, make a note of those, because then they will indicate chronicity. Then peripheral examination, as I told, indentation is very important, because you can miss certain breaks near the ora serrata. If on indirect ophthalmoscopy alone you are able to see the ora serrata 360-degree around, then indentation might not be required. But if it's a trauma case, or if you're missing out on any break, you're not able to find a break, then a 360-degree indentation for dialysis is mandatory. Then choroidal detachment can often be present with retinal detachment, and you will be able to see the ora serrata in those cases very easily if the patient is not myope. In myopes also, without a choroidal detachment, you can see the ora serrata easily. But choroidal detachment, you have brownish mounds which are there in the periphery, and the ora serrata is visible very easily, and the retina may be redundant in the periphery. So that can point to a presence of choroidal detachment. In addition, there would be hypotony in the eye, so that will again point to a presence of choroidal detachment. Now, once you have depicted all the findings, now you have to draw these findings on a fundus chart. Now, the commonly used fundus chart is the modified Amsler-Dubois chart, or it is also called cartogram. You have You have three concentric circles. The innermost is the equator, then you have ora serrata, and then you have the junction of the pars plana and plicata. Now you have cloacas mentioned on this, and the center of this chart is taken as the center of the fundus, that is the macular fovea, and optic disc is made on onto the left or the right of the fundus depending on the eye. Now there are different color codings which are used, notations which are used. So you have red markings which are there. It could be red solid or red lines as you see in this picture. So you have attached retina which is depicted by red. You have retinal hemorrhages, subretinal, you have subhyaloid hemorrhage which is depicted by red. Intraretinal hemorrhage is also in diabetic retinopathy if you have to make, that is depicted by red. Now breaks, if you see the inner margin of the breaks is to be made by red. Then red lines are used to depict open portion of dialysis or giant retinal tears. Areas of retinal atrophy alone. Then outline of lattice degeneration in attached retina. So if you see over here in the attached retina, there is a lattice degeneration, but the margins of the lattice degeneration are shown by red lines if the retina is attached. If the retina is detached, then you show it by blue lines. And the normal foveal reflex is also shown by a red plus sign. So these are the, so commonly if you see attached retina is red and red lines is basically for lattice degenerations when it is in attached retina. That is common. And the normal foveal reflex is red. And sometimes you also have intraretinal hemorrhages which are depicted by red. Then blue markings, anything which is detached. So detached retina is depicted by blue solid areas. Then blue lines, retinal veins are marked. Usually we depict the retinal veins because they are larger, retinal arteries are smaller. So we omit the retinal arteries normally, and we only depict the retinal veins by blue lines. Then outlines of the retinal breaks. So if it's a retinal break, then if you can see over here is a horseshoe tear, the outline is made by blue line, but the interior is made with the help of red color. Now, outline of lattice degeneration, as I told, in a detached retina will be by blue outline. But if it's an attached retina, then it is a red outline. Now, inside of retinal lattice degeneration, when you see the inside of retinal degeneration, then you see the sclerosed vessels. Now, vessels, as I have told, that retinal veins have to be shown by blue lines. So, inside of the lattice degeneration, whether it is attached or detached retina, you have to depict it by blue lines. Then rolled margins of the tear, as it has been shown in the horseshoe tear, it is again by blue lines. And then star fold, which is an retinal PVR fixed fold, it is also shown by blue star fold. Now, anything in the vitreous is, any opacity in the vitreous is depicted by green. So green solid could be for vitreous hemorrhage, vitreous membranes, haloidal ring, that is Weis ring. Then you have intraocular foreign bodies are also by, and retinal operculum also. Sometimes you see operculum in the macular area, macular hole, or you have operculated retinal breaks. Then that operculum is shown by green color. Vitreous substitutes, if there is a gas which is present in the fundus, which is partly filling the eye, then you might have to show it by light green shade. Then stippled green appearance will notation will be for asteroid halosis in the vitreous cavity. Now, anything which is subretinal, which is generally yellow, sometimes intraretinal edema. Intraretinal hemorrhages are red. Intraretinal edema is by yellow circles. Then hard exudates are by yellow dots. And then bruisings again by yellow dots. There is no way to differentiate between hard exudates and bruisings. You can label it in addition to the color notation. Then subretinal bands are by solid lines. Then retinal cyst, as it is shown, you have a blue margin around it in a detached retina, and then there is a cyst. So again, it's a yellow. Then choroidal coloboma is also yellow, the area of defect of the outer retina and the RP and the choroid. Where you see the sclera, it's again shown by yellow. And then you have pathological myopes in which you can see areas of focal choroidal atrophy where the sclera is visible. Those also can be depicted by yellow color. Now, black markings are for demarcation lines, or it could be for cryo, laser, or diathermy scars. And in addition to that, you can have cases of vasculitis where you can have sheathing of vessels, that is also shown by black markings. Brown markings are for uveal tissue, that is for choroidal detachment, as it is shown in the right top corner. You have a choroidal detachment. Now, choroidal detachment is important. It can extend anterior to the ora serrata till the junction of pars plana and plicata. So, according to the location of choroidal detachment, you have to depict it. However, the retinal detachment only goes till ora serrata. Now, choroidal tumors also if you have a choroidal melanoma, then you have to label it again with the brown marking. Now, if we see this patient, the fundus picture, then we see this is how the fundus color drawing will be more or so, more likely. Uh, so the pigmented lattice in the infero nasal part, if you see, it's in the attached retina. So attached retina is depicted by red color, and the margins of the lattice are by red color. However, the inner side of the lattice degeneration, the crisscross vessels, since they are vessels, so you have to label it by blue. So if it would have been in a detached retina, as we see in the detached retina, there is also one lattice. Again, the margins are blue here instead of red because it's a detached retina. However, the inner area where the crisscross vessels are there, that is depicted by blue lines. You have holes which are marked by blue outline, and there is a red center, and then you have a horseshoe tear with blue margins, and there is a red interior of the horseshoe tear as well. Now, macula is just off, and the plus sign is omitted here. But you have to show the plus sign also, either in blue color or in red color, depending on the center of the foveal involvement. If the foveal center is attached, then you depict it by plus red color, which is not visible in this case. But if it's a detached this thing, then a plus blue color would be used to depict it. Now, once you have made the fundus diagram, then you should, or you have done the fundus examination, you should remember the link-off rules, because the position of the primary break will depend upon the configuration of retinal detachment. So if we see the configuration of the retinal detachment in this case, it's not crossing the 12 o'clock meridian. So this is retinal detachment, it comes in the supratemporal retinal detachment, which is not crossing the 12 o'clock meridian. So the break is more likely to be within 2 o'clock hours of the highest edge. The highest edge is at 11:30 clock hours, and so the break has to be between 9:30 to 11:30 clock hours. So the break in this patient is at 9:30 clock hours. So most of the times you will have breaks within 2 clock hours of the superior edge of the retinal detachment. Now, next you come to the diagnosis. You frame a diagnosis. You write down the diagnosis in your sheet. So this is how the full diagnosis of this patient will be: that it's a 48-year-old healthy male with right eye OD primary. It's a primary. It's not a secondary retinal detachment. Secondary occurs when there is an existing tractional retinal detachment, and then a secondary reg develops later on. So it's a primary phakic fresh supratemporal quadrantic regmatogenous retinal detachment with macula off with PVR grade A, because there are only pigment clumps. There are no rolling of the break margins, or there is no fixed fold. So it's only PVR A, grade A. Then you should know the PVR grading also here, because then you would be asked about the different grading systems for PVR. Then supratemporal lattice degeneration with hole and horseshoe tear at its lateral edge, and a pigmented lattice degeneration in attached retina infranasally. And OS, there is no treatable retinal lesion in the left eye. Now, next, you will be expected to tell about the management of this patient. So, management doesn't include the surgical options, but investigation that you would like to do and any supportive treatment that is to be done in this patient before surgery is undertaken. Now, ocular investigation that might be done in such a patient include axial length, when you want to know whether the patient is myope in that eye or in the fellow eye. Then specular count if the patient is pseudophakic and had undergone a complicated cataract surgery. So you would like to know the health of the endothelium. And if there is choroidal detachment, of suspicion of choroidal detachment, then you would like to do an ultrasound to look for choroidal detachment in the periphery. Now, supportive treatment that might be required is a lot of inflammation in the eye, then you can start cycloplegic and topical steroids before the surgery. The surgical options, you have to tell the pros and cons of all the options, enumerate the pros and cons of all the options. Don't directly jump to a particular surgical option. Discuss that you have different surgical options. So scleral buckling, what are the pros and cons of scleral buckling in this patient? So if we consider this patient, the breaks are relatively anterior with no PVR, you can consider scleral buckling. The patient is relatively young, 48-year-old with not significant cataract. So you can consider buckling in this patient. Pneumatic retinopexy, again, you can consider whether it falls in the criteria for pneumatic retinopexy, yes. But if you see the patient resides in a high altitude area, and so there would be an issue if the patient want to fly to Rishikesh or considers going to Rishikesh. So the altitude might be different. So that could be a troubling factor or a factor that could interfere in your management plan when you're considering pneumatic retinopexy or vitrectomy with gas tamponade. Then vitrectomy, yes, vitrectomy can be considered again an option. You have to discuss the pros and cons, give the pros and cons here. Then whether you want to use an encircling element or not in such a case, that also you need to be prepared with, because there is no PVR in this case in this patient, and the risk of post-operative PVR is also less. Then encerclage need not be used. So you should be ready. You should consider all the surgical options in your mind, consider the pros and cons of all the treatment options, and then present them in that manner itself, so that the examiner knows that yes, you have a logical thinking that what are the surgical treatment options and which can be explored in such a patient. Then you might also be asked about the timing of the surgery. What is the importance of an urgent surgery in such cases when you have macula partly off? And then post-operative positioning, what will be the positioning in case you are considering a silicone oil tamponade or gas tamponade in such a patient? If vitrectomy is performed, what will the post-operative positioning and how long you need to consider the positioning? Coming to the next case, this is a proliferative diabetic retinopathy case. So this is the brief summary of the patient. We'll come to detailed workup later. So it's a 56-year-old female patient with complaint of sudden painless diminution of vision in the left eye for past 7 days. She is a diabetic for past 5 years on metformin, hypertensive for past 2 years on telmisartan. History of angioplasty has been done. History of angioplasty is there for ischemic heart disease 5 years back, and now patient is on cosporin. Now, the this visual acuity, intraocular pressure, and anterior segment finding may be informed to you. Otherwise, you have to perform these examination or unaided examination, intraocular pressures. Look for NVI, look for cataract, and even look for neovascularization of angle in case you are suspecting a complicated case with proliferative diabetic retinopathy, and if the intraocular pressures are raised. Now, this is the fundus picture which is there. There is proliferative diabetic retinopathy in both the eyes. In the right eye, you can see the predominantly you can see along the supratemporal arcade at the end, you have a fibrovascular proliferation. There's an NV which is there, flat NV, and you have a lot of hard exudates and dot blot hemorrhages uh, in scattered along the posterior pole. In the left eye, you see there is a neovascularization at disc, and then there is vitreous hemorrhage, pre-retinal bleed, which is there. Macula is partly obscured. Foveal center is clear. So you know that the right eye has neovascularization and the left eye has complication arising out of neovascularization. So how do you work up such a case? In the history, other than the basic history that has already been told, you need to know, elicit the history of diabetes duration, how good is the control of the patient, how good is the compliance of the patient with the follow-up with the endocrinologist and with the medication. If the patient is only on oral anti diabetic medication, or the patient is on insulin, has recently insulin been started, or the patient is on glitazones, because that could affect the macular edema. Then, in addition to diabetes, you need to inquire about other comorbidities such as presence of hypertension, hyperlipidemia. Is the patient undergoing dialysis? Does the patient have anemia? Check the systemic status if possible. Check the blood pressure of the patient. You will be expected to document the blood pressure of this patient. Check for any diabetic foot which might be there. Check for pulses if they are affected. Check for anemia. Look for pallor of the palpebral conjunctiva and assessment of the tongue. So these gross assessment are important in a case of long case of proliferative diabetic retinopathy. Then you have, as I've already told, the anterior segment examination in terms of neovascularization of iris or angle and lens opacity, because often diabetic patients can have uh, premature nuclear sclerosis and cortical cataracts. That could be there, that could interfere in the assessment, or in that may be relevant in the management of the patient. Then you come to the posterior segment examination. Again, it is important that you perform an indirect ophthalmoscopy as well as slit lamp based examination. Then you have to categorize the severity of the diabetic retinopathy and DME. We'll come to this later on. Then you come to the color fundus drawing, complete diagnosis, and management plan. Now, in the management plan, again, as I told, you have to uh, comment upon the investigation that you would like to do before jumping on to the treatment. Investigation will include not only ocular investigations but also systemic investigations, and then you have consultations or referrals and clearances, and then you have the treatment plan for both the eyes. Now, how do you describe the fundus findings in patients with diabetic retinopathy? You have to describe it in the form of ETDRS 7 fields that have been given, that have been co-adopted from the modified early house classification of the standard 7 fields that were used by the ETDRS study as well. So you have 7 fields which are 30° each. The first field is, if you see in the diagram, you have the first field which is centered at the disc, the second field which is centered at the center of the fovea, third field which is temporal to the fovea, then fourth field is supratemporal, fifth is inferotemporal, sixth supranasal, and seventh is inferonasal. Now, there are two horizontal lines which are passing through the superior and inferior edge of the disc, and there is one vertical line which is crossing the disc in the center. So these are the 7 fields, but these 7 fields, they, if you combine them, then it tells you only about the central 100° of the fundus, 100 to 110° of the fundus. But now we know that diabetic retinopathy is not only limited to the posterior pole. Peripheral examination is also important, because peripheral neovascularization, peripheral hemorrhages could also be there, or you can have retinal detachments which could progress to the periphery, that can point to a presence of a secondary rhegmatogenous retinal detachment. So that is also important in a patient with diabetic retinopathy, proliferative diabetic retinopathy. Now, each of these fields, you have to comment upon the presence of intraretinal hemorrhages, cotton wool spots, hard exudates, irma, neovascularization, hemorrhages, or there are obvious pale areas suggesting ischemia. Now, if you consider the right eye of this patient, I have overlapped the 7 fields on the fundus picture. The fundus picture is not a wide field fundus picture, but you can correlate over here that the first field is at the disc. You have to comment upon any neovascularization, any retinal hemorrhages, hard exudates, cotton wool spots, which are present within the first field. Then the second field, which is centered at the fovea. Third field is temporal to the fovea. So in the third field, you will include that there is a neovascularization elsewhere, which is present of this much size, approximately a 1 disc diameter in size, which is present in the third field, not in the first and the second field. And similarly, you comment about the fourth, fifth, and sixth and seventh field as well. Now, the international classification system is commonly used. So mild NPDR is basically only presence of microaneurysm, then moderate, which is more than mild but less than severe. Severe is 4 to 1 rule. You have to be aware of this rule. Then very severe is when there are 2 or more of 4 to 1 rule, and then PDR, and then DME. So DME, as per the international classification system, is apparent presence of retinal thickening of hard exudates. So you need to do a slit lamp biomicroscopy examination to comment on DME. You cannot comment on DME based on indirect ophthalmoscopy examination. Now, high-risk PDR, as has been defined by the diabetic retinopathy study, DRS, you should be aware what is high-risk PDR and what is early PDR, then clinically significant macular edema as described by ETDRS, and then center involving and non-center involving DME, which is recently used, but it is not based on clinical examination. It is an OCT-based examination, but you need to be aware of that as well. So if you see the fundus drawing, you have to draw a well-labeled diagram for these cases. So here you can see, in addition to the color coding that I've told, here you describe the neovascularization by red if they are flat and by purple if they are elevated. So any elevated fibrovascular proliferation will be depicted by green if it's a predominantly fibrous component, or if it is only a neovascularization which is elevated, then you label it by purple. So it's a flat neovascularization if it is there, then red, or if it is elevated, then it is by purple color. And fibrovascular proliferation with prominent fibrous component, it will be depicted by green color. Hemorrhages, I've already told, if there are intraretinal hemorrhages, then by red color, pre-retinal or subhyaloid also by red color, vitreous hemorrhage by green color. Now, then you come to the diagnosis. So, diagnosis in this patient will be a 56-year-old female patient with type 2 diabetes, right eye, non-high-risk PDR with clinically significant macular edema, because you can tell clinically whether it is significant or not, or you can also use the international classification system, whether it is mild, moderate, and severe, depending on the presence of hard exudates and thickening in comparison to the, in relation to the center of the fovea. But you cannot comment upon whether it is a center involving or non-center involving by your clinical examination. Then in the left eye, you have high-risk proliferative diabetic retinopathy with vitreous hemorrhage with clinically significant macular edema. Now, coming to the systemic examinations, we'll come to ocular examinations later. Systemic examination, you have to tell that in the management plan, you have to include these investigations, that you'll get these investigations done to see how well is the control of the systemic status of the patient and get relevant consultations done as well. Now, you may be asked about the relevant trials over here, such as the UKPDS, DCCT, and ACCORD trials, that what was the relevance of intense blood sugar control and intense blood pressure and lipid control in these studies. Now, ocular investigations that are relevant in this case are OCT, fluorescent angiography, and sometimes you might also need to do an ultrasonography if the retina could not be visualized and there is significant vitreous hemorrhage. Now, you may be asked what are the indications of OCT in such a case. So, OCT is required to confirm DME, quantify, and characterize, and then to document the DME before you are treating the patient. And angiography, again, you might be asked whether angiography is required in this patient because the right eye is 618 vision and there is not much media opacity. There is macular edema, but that is the macular edema uh, correlate with 618 vision. If it is not correlating, then you have to consider macular ischemia. Keep in macular ischemia in mind, then fluorescent angiography might be required in such cases. Or if you have a doubt of IRMA or neovascularization, but here you know that there is definitely neovascularization is there, so your management is not going to change. So then fluorescent angiography might not be required for that purpose. Now, coming to the treatment, you have to comment upon the systemic optimization of the patient before jumping on to the ocular treatment, that the patient glycemic target should be achieved. Then, in ocular treatment, the patient, in this case, if we see, has PDR with the DME in the right eye. So, you should know that you should comment that PDR requires PRP. The gold standard treatment is PRP, and DME requires anti-VEGF treatment in the current scenarios. So a combination of PDR with DME if it is there, so then you need to give anti-VEGF injection and then do a PRP later on, sittings of PRP. Then you should be aware of how the PRP is done, how many sittings are required, what are the laser and the laser lenses characteristic that you could be asked. Then in the fellow eye, there was PDR with vitreous hemorrhage. So again, what is the relevance of anti-VEGF injection preoperative in such eyes? Can we only give anti-VEGF injection in such eyes, or is vitrectomy required? So you should be thorough with the treatment plan in such patients, in such cases. Then you might also be asked about the different trials, that is the DRS, ETDRS, DRVS, and DRCR.net trials. The important ones, not all the DRCR.net, but you should be thorough with DRS, ETDRS, and DRVS studies at least. Now, coming to the third case, most of the workups that I've told will be similar in this case, but a salient feature that should not be missed, I'll just comment on that. So it's a 36-year-old male patient with sudden diminution of vision in the right eye for past 3 weeks. Vision in the right eye is 3/60. Pupil examination, if it is not given, you know from the clinical examination that it's a CR which is there, but you have to assess the anterior segment in these patients, assess the pupil, assess the neovascular, assess for neovascularization of iris or angle, and check for intraocular pressures in these patients. So you know the diagnosis is CRVO then, but then you have to make a comment on whether it is ischemic or non-ischemic based on your clinical examination. So based on the number of hemorrhages, pupillary examination, visual acuity assessment, and disc edema or macular edema, then you have to comment whether it is ischemic or non-ischemic. Then once you, in case you have missed, then you can always revisit the anterior segment examination and check the intraocular pressures. What additionally is important over here is the management. The first line management in this patient will be a systemic optimization, systemic investigation and optimization. Just don't jump to the ocular treatment. It's a young patient who has had CRVO, so you have to investigate the patient thoroughly. So you have to tell about the assessment of for the coagulation profile in such a patient, and then the treatment options for ocular treatment, anti-VEGF and steroid or steroid injection, different regimens that may be that are used. So you should be well versed with the PRN treatment or treat and extend treatment. And it is important that you always mention that you have to monitor the patient for neovascularization and intraocular pressures, and later on, patient can develop neovascular glaucoma as well. Now, case four, again, it's a straightforward, it's a macular hole. But what things are in additionally important here is that you need to comment on the concurrent problems in this patient of macular hole, comment on the presence of epiretinal membrane, comment on the shape of the macular hole, whether it is circular or whether it is irregular, associated with any signs of trauma, whether PVD is present or not in form of V's ring, whether there are peripheral treatable lesions which are there, because those could be associated with PVD. And then you have to comment on the staging of the macular hole, whether it is gas staging or the IVTS staging. IVTS is based on OCT base, so try to restrict yourself to gas staging itself, that's stage 1 to stage 4. Then important investigations that are important here is your Amsler grid examination. That is very important here. So you, in case you have any long case in which you have macular edema or macular hole, then try to do the Amsler grid examination. If you have CNVM, then also try to do an Amsler grid examination. Ask for an Amsler grid. In case Amsler grid is not available, then you can draw an Amsler grid yourself and then assess the distortion as well. So it is important that you assess the Amsler grid. You should be aware of how Amsler grid examination is done. Then you should be well versed with the different OCT indices, although you may not be asked, but if you are very well, if you have performed very well in your clinical history and examination part, then the examiner might also ask you about the OCT indices, which are relevant to the case, and role of FAF also. And then finally, you have the management plan in which you have to comment on whether vitrectomy or alone is required or ILM peeling with flaps. What is the gas tamponade that is required in this patient? Prone positioning, post-operative management, and prone positioning that is relevant in this case. So your again management. If you have reached till the management, that means your clinical history and examination part has gone very well. What is important over here is that you should ask for the history of distortion of vision, central scotoma, and then do an Amsler grid examination in this particular patient. To summarize, when we are working up a long case in retina, anterior segment examination is also important. Don't miss on anterior segment findings. Don't just restrict yourself to an indirect ophthalmoscopy examination. Perform a slit lamp biomicroscopy examination. Document that you have done the slit lamp biomicroscopy examination, and document that in addition to the indirect ophthalmoscopy, what additional findings you have observed on slit lamp examination, whether there is macular edema or there is a lamellar or full thickness macular hole which is there, or any macular ischemia signs are there, sclerosed vessels at the macula, which could be seen. Then properly document all the findings. Use an Amsler device chart to draw the fundus findings in all your cases. Classify the disease as per the need, whether it is diabetic retinopathy, then classify as per the classification systems. Classify the DME if it is present. Keep differentials in mind. Differential diagnosis have to be kept in case you have differential diagnosis. If the history is not clear, if you have a proliferative retinopathy case, then keep differentials of retinal vein occlusion, vasculitis, and hemoglobinopathies as well. Sorry. Investigate the patient as required. Always include investigation in the management plan. Do not omit the systemic investigation and systemic management also. Keep the pros and cons of all the treatment options, describe all the treatment options which are available, and then comment whether which treatment option do you consider the best. So I think if you go by a systematic manner in the systematic manner of examination and documentation of clinical findings and management plan, then I think your long case should go very well. You should not miss on important aspects that the examiner can later on ask you.
Hello, sir.
Yes, Dr. Barnard.
Yes, sir. Thank you so much. You actually briefed, and it was a great summary regarding all the long cases in retina, and especially you told in which particular order we need to go about every case, because that's what is expected in the examination as well, right? All right. So like we asked this particular question in the previous session of glaucoma as well, because glaucoma and retina have landmark trials, and we usually are asked about all those things. So you mentioned about the landmark trials regarding diabetic retinopathy. Can you still brief a little about that?
Okay, so if you have a long case in diabetic retinopathy, then you should be well versed with the trials, which are diabetic retinopathy study, then early treatment of diabetic retinopathy study, that is the ETDRS trial, and then you have other trials in pertaining to surgical retina, such as diabetic retinopathy vitrectomy study. And then you have certain trials which are relevant for the systemic control and what is the relevance of comorbidities in the diabetic retinopathy, such as you have the VESDR, then you have DCCT, UKPDS, and ACCORD. So these four trials in the assessment of the comorbid and the comorbid status in the diabetic control, you have VESDR, then you have DCCT, UKPDS, and ACCORD. These trials are important, and pertaining to the diabetic retinopathy and surgical management of diabetic retinopathy, you need to be aware of the diabetic retinopathy study, ETDRS, and DRVS study. Now, most important of these studies, if you consider overall, are the DRS and ETDRS studies. So you should be aware of what were the three main objectives of DRS study and what were the three main objectives of ETDRS study, and what were the outcomes of those three objectives. So you should be thorough with the three objectives and three outcomes which are there of these two studies, because these are the landmark trials which have governed and which have uh, uh, standardized the treatment as well as management of diabetic retinopathy and DME. So you should be thorough about the DRS and the ETDRS studies at least, and then you should know briefly about the other studies such as WESDR, UKPDS, UKPDS, CCT, because again you might be asked about the relevance of intensive blood sugar control, lipid control, and blood pressure control in your patient.
Okay. And pertaining to diabetic macular edema and all the injections, like which one do you think we have to know?
So injections again, based on your clinical examination, you should know whether there is clinically significant macular edema which is present or not, or you can further categorize it as mild, moderate, and severe as per the international classification, wherein in mild you have edema which is away from the center of the fovea, in moderate you have edema which is approaching the fovea, and in the severe you have edema at the center of the fovea. So if you have clinically significant macular edema or you have severe macular edema, then you need to treat those patients. Now, the treatment options could vary. The first line treatment approach, in you should always mention that you should use anti-VEGF agents. If there are no contraindications to use, such as the patient might have had recent history of coronary artery disease or cerebrovascular accident, so then in those patients, if in the last 6 months they had a recent episode or there is worsening of the cardiovascular status, then you should avoid using the anti-VEGF agent. So that's why it is important that you take a relevant, thorough history of the comorbid status of the patient as well. And if there are any contraindications, then you can consider using steroids also in such patients. And then regarding the treatment regimen, you have PRN treatment and you have the treat and extend treatment. So you should be aware what is PRN treatment, prurine as and when required treatment, what are the benefits of PRN over treat and extend, what are the benefits of treat and extend over PRN, what are the different anti-VEGF molecules that are available with us, which could be tried, and similarly, what are the different steroid implants and steroid injections that could be given in such patients? So you should be aware of the indications and contraindications of all of these.
Okay. In
Also,
fact, the recent advances as well.
regarding there are certain trials for management of DME also which have been given by DRCR. So you should know about the DRCR R, S, and T trials which are relevant for the management. So and the T as well, in which the various drugs have been compared. So those trials are very relevant, and you need not go through the through all the trials, all the 50 trials which would be there for DRCR not .net. The important trials such as the DRCR .net R trial, then S, T, U, V. These are the important ones which are there pertaining to the treatment of diabetic retinopathy and DME.
Okay. All right. Just one practical question, sir. It's not related very specifically to the academics. In case, like sometimes the long case gets swapped as a short case. Like for example, PDR can be a short case as well. So what do you expect? Because we have only close to some 15 minutes. Like what do you expect during that time?
In a
In
short
case if a long case is swapped as a short one.
things, you're not expected to take a thorough history. You're not expected to do an anterior segment examination. You directly have to jump to the posterior segment examination, do an indirect ophthalmoscopy, but don't miss on slit lamp biomicroscopy. That will be expected. You will be expected to have performed a slit lamp biomicroscopy examination. And in addition, indirect ophthalmoscopy is not required in those cases. But yes, because diabetic macular edema, CSME, and a lot of other macular pathologies, they could be picked up only on slit lamp biomicroscopy. So you should do a slit lamp biomicroscopy and describe that you have done the slit lamp biomicroscopy, so that the examiner has confidence in you that yes, you are aware that a slit lamp biomicroscopy is to be done in assessment of macular function, macular structure and pathologies. So you directly jump to the retinal examination. You don't have to do any anterior segment examination in those cases. And then if it's a PDR case, then you have to comment on what is the classification. So don't miss on classifications, whether it is highest PDR, whether it is early PDR, whether there is complications. Then you have to comment on the macular edema, whether it is CSME or whether you want to define it by mild, moderate, and severe uh, edema, and then you come to the management accordingly. So management will remain the same. You have to comment upon the systemic as well as ocular management of the patient. And in ocular management, include the ocular investigations also, that you would like to do OCT, irrespective of whether edema is clinically present or not, because clinical examination may miss edema. So OCT is to be included. FA may or may not be included. You should know what are the indications of FA, and then you have to present your treatment plan.
All right. All right. So that's all from my side. Dr. Megha and Dr. Ashwita, do you want to ask any questions from your side?
So this is again a practical question, not academic question. Most of the retina patients that we see, especially for diabetic retinopathy exam cases, they already have a long history of many years where they may have gotten a lot of anti-VEGF injections or laser treatments. But hello, am I audible?
Yes, you are audible.
Yeah, yeah. But we are not
Yeah, you're
allowed to
audible now.
access the files, and the patients.
Not know the So you're not expected to know the details of all the injections. You should inquire from the patient that have you been given injections in the past? Have the injections been frequently given? And when was the last injection given? And how has the response been? So these 3-4 questions you can ask. You need not go through the history of all the 10, 15, or 20, maybe 100 injections that the patient might have received in the past. Just ask,
Okay.
injections have been given in the past,
Okay.
and how frequently they have been given. Was there any response to injection, and when was the last injection? So that
All right.
would, okay. And similarly for laser, when was the laser done? How many sittings of the laser were done? So you need not know the exact date, but yes, it was done 6 months back, or it was done 1 year back, whether it was done 2 weeks back. So
Right.
that the patient will tell, and how many sittings the laser has been done, that also the patient will inform. So you
I
don't
think that is that.
need. So most of the patient will know. They will tell that yes, my laser has been done 2, 3 times. It has been done. They may not remember the dates, but yes, they will tell that laser has been done and multiple injections have been done. Patient always, they need not look at their card. They will know that yes, they always tell you that yes, multiple injections have been given and the least recent injection was given on this date. They will know. That much is sufficient for your
Yeah,
assessment.
as a postgraduate, I feel like the history part of retina is the most convoluted one because they have so many treatment sessions that they've undergone. It tends to,
Patient would have received multiple treatments out.
yeah.
The patient would have presented to you. Yes, that would be one problem. But in exams, generally, we don't keep cases in which there is so complicated history or the cases are so complicated. Generally, the cases will be straightforward. Generally, the patients will be treatment naive who have proliferative diabetic retinopathy changes, and there are no laser marks. Generally, the fellow eye might have some laser marks, and this eye, one eye might have vitreous hemorrhage or tractional retinal detachment. But then, not much treatment would have been done. Generally, we try to keep patients who have simple findings, so that we don't want, obviously the examiner doesn't want to trouble the students as well, but sometimes you have due to the lack of cases or paucity of
Yeah.
cases, we might have to keep cases which are available that time. So in those cases you might have one odd case in which there is a very complicated history and complicated findings.
True, true.
Those cases, keep your calm, take relevant history need not after irrelevant history. Now, how many times the patient has got injection, it's irrelevant. How many times, whether it is 10 times, 15 times, 16 times, 20 times, it's not relevant. What injection also, it is not relevant. Yes, he has received injection, and how frequently he has received injection, when was the last injection, only this much information is more than enough.
And
Yeah,
so clinic,
probably
since
we'll
we
save
won't be
time on
able,
that as well.
yeah, since won't be having the OCT of the patient, clinically we can just say that,
Don't ask for the OCT, don't comment on the OCT.
yeah, we
Don't
can just say that there is clinically we can see macular edema. I would like to get an OCT.
just comment on the clinical findings. Never ask for OCT. Even if you go through the patient card by mistake and you have an OCT printout, never comment that you have seen the OCT or you have asked for an OCT. Okay.
Thank you.
Findings which are seen on clinical examination, you have to tell, and then you can include in your management plan that OCT is required in this patient to document the and confirm the findings.
Ashwita?
Dr.
I
Ashwita.
think a common question which examiners ask is in unilateral PDR, what are the systemic associations or manifestations you need to rule out? I think you could brief about that. A lot of examiners ask these questions to the PGs.
So unilateral PDR, or more commonly you call it asymmetric PDR. Okay, asymmetric DR. So asymmetric DR is something which is very well recognized entity, and it is like you need to have PDR in one eye and NPDR in the other eye, and there should be at least two grade difference between the two eyes. So one eye, so you have the grading system, you have mild, moderate, severe, very severe, and then PDR. So you need to have PDR in one eye, and you need to have in the fellow eye either mild or moderate NPDR or severe NPDR. If there is very severe NPDR in one eye and PDR in another eye, then you don't label it as asymmetric DR. But if it is PDR in one eye and mild to severe NPDR in the other eye, then you can label it as PDR, given you have followed that patient for at least 6 months and you have noted that the status has remained same. Because always there will be some asymmetry which will be there in both the eyes. So it may be possible that you have seen a patient now, there is PDR in one eye, other eye is severe NPDR. 3 months down the line, the other eye also develops PDR. So then you don't label it as a asymmetric DR. For 6 months, you have followed the patient. The disease remains the same in both the eyes. That is PDR in one eye and mild, moderate to severe NPDR in the other eye. Then you label it as asymmetric DR. And then it is important that you investigate such patient for ocular ischemic syndrome. So there is a compromised blood vessel supply to the eye which has PDR, because the retinal findings are getting exacerbated because of the poor ocular blood flow, and you need to get a carotid assessment of such patient. So you may be asked, I don't know if there is a examiner who want to grill or want to trouble you, then the examiner may ask you about the carotid pulse examination also. That did you examine the carotid pulse in this patient? Did you look for the feeble pulse in the carotid on this side of the eye, which is affected more? Okay, so that could be asked by the examiner. So accordingly, then you have to revisit the examination. Okay, so now once you know that there is asymmetric DR and it could be ocular ischemic syndrome, then you have to look at certain other things. That you have to look at the carotid pulse, you have to look at the intraocular pressure of that eye, whether it is disproportionately lower in that eye, whether the cataract is more in that eye, whether there is anterior chamber cells or flare in that eye, whether there is neovascularization of iris in that eye, and whether the diabetic retinopathy changes are more so in the mid periphery or periphery as compared to the posterior pole. So all these findings will point to a presence of additional finding of ocular ischemia.
All right. So I think with that, we'll wrap up the session. Thank you again. Retina is loved by almost all the postgraduates, I'm very sure, because we exactly see what we learn very significantly, that too. So thank you so much, sir.
Thank you, everyone. Thank you, everyone.
Yeah, we'll meet on 14th of May for Approach to Long Case Orbit by Dr. Pallavi Singh. Until then, see you guys. Good night. Have a nice weekend.
Thank you. Thank you, everyone.
Thank you, sir. Good night.
Thank you,